let's see this. Ah, done. Good.
Superb, great.
Okay, so just let me. طيب, can we use this هيدا لنتعرف على some of the attendees?
Yeah, sure,
If you
please.
want.
Yes.
Can you please just introduce yourself? Some of you probably I know.
Okay, so we will do that. We will start introducing the participants. But in the meantime, Anna can kindly requested from my colleague Nesmiati to ensure that the recording has you على البيج مش مع حدا تاني. So I'll begin with myself with all بس لأنه أنا سائبة أول صورة. You know me, Firas. I'm your colleague. So I'm founding director of the bioethics program at AUBMC. Nesmiati on. Thank you.
Hi.
Hi.
So I'm Diana. I'm the program coordinator of the bioethics program. And,
Hi, Diana.
I hope this talk is making people.
صوتك عم بيقطع كثير يعني for some reason. Okay.
Can move to that.
Okay. Anthony, can you please introduce yourself? Madam Bahira, can you please introduce yourself?
I think the problem إنه العالم ده منهم قاعدين إن هيدا, so nobody knows whose turn it is.
عشان هيك أنا I'm calling the team. So Anthony Hakim, can you kindly introduce yourself if you are able to use your audio? So we'll count till 3. Madam Abbas, would you kindly introduce yourself?
Hello, my name is Bahira Abbas. I'm the special ed instructor at International College, and this is a very interesting meeting. Thank you, Dr. Arawi, for this. Thank you, Dr. Firas. Thank you.
Thank you for coming.
Thank you. Mrs. Bara'a Hajjar, I think. Can you kindly introduce yourself?
Hello, it's Mr.
Okay, sorry. So
No
please
problem, no problem. Okay, I'm a student in AUP, chemistry pre-med, so I was interested in this meeting, so I registered to it.
I did my pre-med as chemistry, so I feel the connection.
Interestingly, I started my pre-med and I withdrew because I fell in love with philosophy. So I'm a shift major, but still we have something in common. Elsa?
You made the right decision.
Yeah.
Hello, I'm Elsa. I'm a 2 student. And it's very interesting to be able to talk to Dr. Abid and Dr. Arawi. Thank you.
Thank you.
Mr. Farouk?
Farouk Marabi. I'm a director of environmental health, safety and risk management at AUB.
All right.
Thank you for attending, Farouk.
I'm a chemistry major with AUB.
Thank you. حشيل الألقاب for the sake of not making any errors. For Fatima Saad. Hello everyone, my name is Fatima. I work at Embrace and majoring in psychology. Okay. Good. Jad Assaf.
Hello, I'm a medical student at AUB, and I've been following you, Mr. Abiad, on Twitter for some time before the COVID pandemic. You've got nice people.
Who isn't, ya
I
Jad?
hope we didn't disappoint.
Right.
Marita Saliba.
Good evening. I'm a Med 1 student at Balamand. I graduated from EP with a Bachelor of Science in Biology, and I'm excited for this session.
Thank you.
Thank you.
Thank you for coming.
Matthew?
Hello, I'm a Med 2 student at AUB. I was also a philosophy pre-med and extremely interested in this talk and also a big Twitter fan.
Thank you.
Peter Abu Fadil.
Hello, I'm Peter, and I'm also a Med 2 student and also a fan on Twitter.
Allah يخليك. Thank you, Peter.
Tala Al-Khansa.
Hello, my name is Tala Al-Khansa. I recently joined the bioethics program team and as a research assistant, and I'm looking forward to this talk.
Thank you.
Thank you.
And I'm looking forward as well.
And last but not least, at least so far, Zina Hamza.
Okay, good. So shall we start?
Zina, بدك تقول شيء? Okay, I think let me just start by introducing you, if you don't mind.
أبدا.
Okay, so بس كمان a kind reminder to Smiati to ensure your WebEx screen that is being recorded is basically your screen, not ours. So it is true pleasure to have Dr. Firas Abiad with us. Please, if you can mute your phones if you're not speaking, it will help. So Dr. Abiad, I'm going to go personal شوي هون. I remember when I first met Dr. Abiad in one of our MedEd meetings. And I usually trust my first impression. The first impression that Dr. Abiad made on me was someone who was wise enough not to speak a lot and whose facial features revealed a lot of serenity and a lot of humility. So I am happy to introduce him not only as a colleague, but also a friend whose presence speaks about his character. He is currently General Manager and Chairman of the Board at the Rafiq Al-Hariri University Hospital, which became one of the top hospitals lately in fighting COVID-19. He is also a gastrointestinal and bariatric surgeon at AUB and an educator. Dr. Abiad has recently been recognized as Man of the Year by the Arab Hospital Federation. وشكرا كثير for giving us your time, Dr. Abiad. And if I may, I have a few questions and you can just answer them the way you want, and this discussion can go smoothly and not unprepared. يعني. So أكيد, I expect everyone to wonder what is the current situation in Lebanon. But I wanted to add that I understand the rate of infections have been reduced, yet the testing as well has been reduced, which makes me wonder whether the reduction of infection is almost non-scientific or of any value. So what's your stand about this, vis-a-vis this?
First of all, thank you, Thalia, for your kind introduction, kind words. And indeed, it's my pleasure to be with you and with our colleagues, junior and senior. And actually, I'm looking forward to what I'm sure it will be a stimulating discussion. Going to our current status, indeed, the number of tests has gone down. And unfortunately, when the number of tests goes down, you're not able to really assess what is happening. If any one of you was following the tests we were doing, حتى لما when we used to have almost 1,500 or even less number of cases daily, our tests were in the 13 and 14,000. So the positivity now, so because we are not over-testing, if you want, we are not catching enough cases. How do we know that? There are several ways to know. First of all, if you look at the asymptomatic cases, the percentage of the tests that is coming from asymptomatic cases is almost between 26 and 29%. Worldwide, it is 50 to 60%. That means that we are not testing enough in the asymptomatic category. Mean in the asymptomatic category, usually you catch them in the contacts. So you have somebody who's positive, you test his contacts, and you find them. Some of the times it's not only asymptomatic, but also what's important, pre-symptomatic, and you isolate them quickly. And this is how you stop the spread of the infection in the community. So when you don't do enough testing, that means you're not catching enough. That means that, unfortunately, you will not be able to stop the spread as you should. And unfortunately, what you will see is that most of the testing becomes focused on the on the symptomatic patients, and this is why, you know, the chances of catching people, the positivity of your test goes up, لأنه you are mainly concentrating on a higher risk category. So actually, it's not good that your test positivity rate is high, because usually that means that your testing strategy is not that great. The WHO puts the testing at, you know, your test positivity should be less than 5%. Our testing is above 15%, and it's going up. Going into the ethics of testing, which I think is important for all of you.
Absolutely.
The problem we have is that testing is not being done for free. So effectively, we are seeing skewed testing in the sense that testing is concentrated, because it's mostly done in private labs and in people who don't afford it. So we see a lot of skewed testing. The tests that are being done, in the opinion of a lot of experts, does not really reflect what's going on on the ground. And that's why we are looking always at other indicators, such as the admission to the ICU and the number of deaths that are happening. And probably I would think that this three combination, test positivity, admission to ICU, and the number of deaths, probably will tell us more about what's happening in the country than the number of new cases caught per day.
طيب Dr. أبيض, if I may, لأنه عم نحكي, since we're talking about testing, I wonder how, if at all, and to what extent has testing also been carried out among refugees, migrant workers, since most of them cannot afford it.
بالrefugees,
it's a ticking bomb population, as you know.
So the refugees, there are two guarantors who are taking care of refugees. عندك UNHCR اللي هن بيهتموا they take care of the Syrian refugees, and the UNRWA that take care of the Palestinian refugees. So UNHCR does cover the tests, especially for symptomatic. And one point they did a screening in the camps, and the return was very low positivity. But as you know, the problem with PCR, it gives you an indication of what's happening now. It cannot tell you what's going to happen, for example, in 10 days or 1 month or 2 months. So to be able to know what is happening on the ground, you have to combine that with some kind of seroprevalence studies. And there are plans of doing this at the moment in collaboration with WHO. Now, with the Palestinians, the story, unfortunately, is much sadder, because there are a lot of constraints on their budget, and actually they're running out of money. And therefore, the budget for testing now is being concentrated mostly on symptomatic patients. And this is unfortunate, because that means that you lose the chance of catching people early in their disease and isolating them. And if you don't do enough testing, you end up by having one of two options. Either you don't catch them early, i.e. the virus becomes rampant in the society and we see more and more cases, or you have to use blunt tools such as lockdowns, which unfortunately are not very good for the economy, especially in communities who live hand to mouth, so to speak. So it really devastates those low socioeconomic communities. Hello?
Sorry. So among prisoners, كمان are we testing as much as we need?
Prisoners, the prisoners, there was support from WHO and others, and we are able to do serial testing in prisoners or in prisons. One of the things that can possibly become a game changer is the arrival of the rapid antigen test. So the rapid antigen test is a test that detects the antigen, not the antibody. It doesn't take, the result can come back between 15 and 30 minutes. And the cost today, it was priced at almost 1/3 of the cost of a PCR, and it doesn't require the same logistics as PCR. It's much less demand on the logistics. It can be done anywhere. And probably this will help a lot in increasing the scope of testing. But most importantly, it can give you an almost immediate result, because remember, one of our problems in Lebanon with testing was not only testing, it was reporting. The problem is if you do a test but you don't get the result till 5 days later, the test is useless. لأنه أنت in 5 days, the person who was tested, especially إذا كان عم يعملوا بلاب, not in a hospital or he's being admitted, he will not isolate themselves, and they keep on going around in society till they get the result of the test. In 5 days, they would already have infected, whoever they infect. Remember that most of the studies done on COVID suggest that the infectivity window is about 4 to 5 days. I mean, that is the window by which people can infect. And some people are much better at infecting others. They are super spreaders. These are some of the new informations that are coming more and more, coming about COVID.
Look, so thank you. So since we are talking about refugees, migrants, and others, and we are also talking about the government, the Ministry of Health, getting hopefully the Pfizer vaccine somewhere mid-February or beyond. But we also know that unless 70% of the population is inoculated, we are not doing much. And it's not going to be for free for all. So do you really think that the strategy that is being followed or about to be followed will actually ensure that the pandemic is controlled and that justice is taken care of? Yani, even the non-well-off will get it?
هلا نحن remember we need 60% of the community to have some kind of immunity. Okay, and immunity you get it from either the vaccine or you get it from getting the disease. هلا my estimate and my the official number of how many people in Lebanon have got the COVID is about 100,000. And I estimate that for each known COVID patient, probably there are 3 or 4 patients who we did not detect, whether it is because we didn't test, they did not show up, they were asymptomatic and just went below the radar. So if you think about that, that means that probably about 10% or a bit less than 10% of our population already have some kind of immunity. Now, one can argue that, there are reports about people who can getting reinfected, correct, but extremely rare. So for all practical purposes, for the time being, we can assume that, this immunity is going to stay with us sometime. So if we have 10%, and probably by the time we start giving the vaccine, which in my opinion will not happen before March or April, we are talking about probably 15% of the community already getting natural immunity because of infection. And if you add to that another 15%, that's 30% of the community. So we are going in that direction. Now, is there another strategy? There isn't another strategy, because the other strategy of making everybody, infecting everybody, or what's called herd immunity, carries at least 0.2 case fatality rate. So we're talking about, to get, if we consider that everybody in Lebanon is going to get immunity by getting infected, we're talking about at least 12,000 deaths minimum. So this is, in my opinion, a completely unethical course to follow, to be honest. Especially now that the vaccine is almost near. Now, the good thing about the vaccine is that it seems that there are more than one vaccine. The Pfizer vaccine, the major problem with it is the logistics. لأنه Pfizer, it requires a minus 80 degrees refrigerator, which is not available in a lot of places in Lebanon. At Hariri, we have 2 of them. And I'm sure like at AUB, probably they have 5 or 6. But the problem is you're going to distribute this all over Lebanon. So you need to make that available. You need to make sure that there is 24/7 electricity, so on. And then you need to, because these patients need to take 2 shots. There is a period of about 28 days between them. So a lot of logistics that makes it a bit cumbersome. And what's promising is the other vaccine that is coming from Oxford, which also shows in one of the protocols, a half and one, that it has around 90% efficacy, efficacy, yes. AstraZeneca, it has about 90% efficacy. And what's good about it is that it doesn't require, I mean, it can, you need a regular fridge. You don't need the -20 from Moderna or -80 from Pfizer. And also the cost appears to be about between $2 to $3 as compared to probably what's going to be around $30 for the Pfizer, and that's for 1 shot. So 2 shots, probably you're talking about at least just from the price, زمان نحكي عن logistics, $60. So the AstraZeneca, the Oxford, if the protocol, if we follow this other protocol, يعني في 2 protocols, واحد عنده كان 60% efficacy, the other one 90%. كمان هيدا holds a promise not only because of it is, it's easier for logistic wise, also it appears to be cheaper. So the third or the fourth, actually, vaccine out there is the Russian vaccine. But obviously, more data are required about it, but also it's going to be cheap. Finally, remember that I am sure international organizations, we heard about the G20. A lot of people are talking about making the vaccine available to low resource countries. And unfortunately, Lebanon now is an extremely low resource country. So, also we are going to get it from other sources as well.
No, I think also the Ministry of Health, and it's not used, it's all over the internet, has already made an agreement with COVAX, which will allow the selling of the vaccine for around $15 maybe. But still, it is a problem.
Yes. The issue بعد لهلا حتى الفايزر or Moderna, they didn't even price their vaccine. So we need to wait and see, when they get it. The other thing is, are they gonna subsidize it? لأنه بالنهاية it's a medication. So even حتى لو كان مثلا $60 but at a subsidized price, it might be a bit more affordable, for example, than if it was true fresh $60.
So unfortunately, and you know this, Dr. Abia, probably from your work as a physician, there are many people who have the mentality that a more expensive vaccine works better. Do you see that if we have this Pfizer, Moderna, or AstraZeneca vaccine, people are going to say, so only the rich and the well-off will get the Pfizer, which is most probably better than AstraZeneca, بس نحن عطونا الAstraZeneca for financial reasons. So this is the story.
Okay. شوفي Thalia, I think you're hitting on a very important topic. So there is a recent study that we were conducting with Ghina in the OBGYN about attitudes towards COVID and so on. And one of our findings was that people from lower socioeconomic classes tend to have less scientific information about COVID and so on, and they tend to believe more some of those sayings that are shared on social media and so on. And unfortunately, one of the areas that have been really affecting us in a bad way in our approach to COVID has been the absence of good communication. And I'm not talking about communication, I'm talking about the general awareness campaigns that especially targets people coming from less scientific backgrounds or lower socioeconomic classes. We are not able to communicate well with them. And unfortunately also, this issue of trust that you raised is there. I mean, in Lebanon, we have to face it that people don't have a high level of trust in their in the government, and all of this, goes into how much will this vaccine be received. Will we hear tomorrow, for example, somebody taking the vaccine having a side effect that can be spread over the social media, similar to some of the things that we heard before, like that hospitals are paying for dead COVID patients, and. So I think that part of the logistics and preparing people for the vaccine will have to be a media campaign that that targets people and hopefully increase the level of acceptance of the vaccine. Having said that, I think that one of the things that we are seeing in Lebanon, especially as unfortunately the number of deaths is rising, that people are becoming more aware of COVID as a bad disease, and that this is something that if they have access to something that might protect them, I think that their acceptance is going to be high.
Yeah, I noticed many people who say "ma fi corona" have changed their mind when their relative or friend has gotten corona. So absolutely
true. And remember, in addition to the now almost 900 patients who passed away, unfortunately, we have even a bigger number of patients who've had a very bad corona. And those people, in my opinion, are even more important, because as they talk about their bad experience with COVID, they are also helping us spreading awareness about, that COVID is not just a flu.
Yes, absolutely. So, Firas, you mentioned a lot of important points that there are two things that I would like to raise based on what you noted. The side effects. And this is one thing that I raised yesterday with the ministry. And Pfizer, we did the phase 3, but it was done quite rapidly, if I may. And in that sense, whenever the vaccine is going to be administered, it is going to be one way or another experimental. We're still not aware of the side effects 100%. So should side effects ensue, will we as Lebanese government and our government treat the side effects? Will Pfizer treat the side effects?
Becky, I think that with pandemics, you always, and I think there was a very nice talk from somebody from WHO around this, and that is, what do you value most? Accuracy or speed? I think that, if you talk to people who work in development of vaccines, the thing that they keep telling you is that usually it takes years to develop vaccines. And one of the reasons why it takes all of this time is to look at not only efficacy and efficiency and so on, but also to look at side effects, the things that we might not see till a lot of time has passed. Now, what's happening with COVID, unfortunately, is if you consider the effect it is having not only on health, but more importantly on economies. It is crippling even, healthy economies. And I am sure that we are going to see a lot of deaths, not directly from COVID, but from the aftermath of the COVID in Lebanon and so on. I think when you put that all into perspective, it appears that the side effects of the vaccine, if they happen, are going to be, less, I don't want to say negligible, but, it's going to be, the benefits are going to outweigh the risks coming from the vaccine, at least from the information we are getting now. And one of the things that the Ministry of Health has said is that it's not going to go into a vaccine unless that vaccine is supported by the WHO. And I think that this is an important thing, because we are not going to politicize the issue of vaccines. I think this was a concern for a lot of people at one point when, for example, the Russian vaccine initially came up and so on. And people were concerned is that, will we ignore the safety issues just to be able to get our hands on a vaccine from, and I think that the approach that now we are hearing from the ministry, and that is that they're going to follow in the recommendations of the WHO should reassure a lot of us that, you know, safety will be something, of concern.
So I'm going to limit myself. Yes. We're going to give us just 5 minutes, and we're going to leave the floor open for the participants, if that is okay. مش الحال؟ أهلا. Thank you, Hassan. So very quickly اسمح لحالي بعد سؤالين بس, and then I'm going to force myself not to ask. Leave the floor for Diana and the participants. هي do you think, I know it's a public health crisis, vaccination should be made mandatory, which is problematic, that's the first question. The second question, do you think, I mean, I know it's an emergency situation, there will be something like an informed consent prior to taking vaccine? So thank you.
So I think these are important questions. I think informed consent is, I think it is warranted because this is a new vaccine. There is no discussion about that. There are some unknowns. Already now we have a lot of questions that are being raised about, for example, how much will the vaccine help in prevention of very bad cases, critical cases, the role of vaccine, for example, in the asymptomatic patients that was not addressed in the Pfizer study, but or we don't have any information, but the AstraZeneca study talked about that. So there are a lot of questions, and probably I think when we have a lot of those questions, it's always better to have an informed consent available. Now, obviously, the question is, will it be a proper informed consent? Will people, will everything be properly explained so that people can consent appropriately or not? Now, concerning the other, can we force it? Now, this is an interesting discussion, and I remember I was talking with Dr. Mukhbat about, for example, like in AIDS, can you force people? Can you make it against the law? For example, if when they are having a sexual intercourse, if they don't wear condoms, for example, would that be considered somebody breaking the law? Would it be considered breaking the law if you don't wear a mask when you leave your house, or is this part of a personal freedom? Now, my understanding and what was explained to me, that the law says that if this action, you are endangering others knowingly, and here somebody who has COVID or might have COVID, and he is not wearing a mask and thus endangering others, then you are liable. So here, I think that this can open the place for discussion on this. But having said that, for example, something similar happened at RHUH the last week when we were giving flu shots to our staff, and some of our staff said they do not want to take the flu shot. And we were discussing whether we can, as an institution, can we force them, or at least tell them that, anybody who, it's mandatory for anybody who wants to work in Hariri to have received a flu shot. And what happens if somebody refused? Will we kick them out? Will we deduct from their salary and so on? And we haven't finished that discussion, to be honest. We are trying to explain and make people reach that decision on their own, not using force. I still cannot see us forcing people to take the vaccine.
So just to follow up on that, لأنه بيعطي الدور لغسان and others. هلا الفايزر vaccine have not, or others, a clear answer as to whether people will continue being contagious or not, and has not been experimented on pregnant women or children. So
yes, not to my knowledge, correct.
So what happens,
or at least the information has not been shared.
Okay, so what happens in this case? لأنه they might still infect others, and students, for example, parents who refuse to vaccinate, they cannot vaccinate their children, and we're back to square one in schools.
True, Talia, but remember that probably by the time we receive the vaccine and we reach the stage where the vaccine, initially the vaccine will be given to the healthcare workers, frontliners, first responders, and high-risk patients, like people, for example, elderly, nursing homes, comorbidities, and so on. So I think that by the time we reach the stage where we need to go and talk about, for example, people in, pregnant or children, so you know that, for example, children, they have a very low or lower rate of getting the infection, getting infected than, for example, adults. So I think that by the time we reach there, probably we will have more data that will allow us to make a better informed decision.
Thank you, Firas. I leave the floor to my colleagues for any questions and participants. كان في Monsieur Ghassan كان بده يسأل سؤال and I apologize for interrupting.
Yes, hello. Do you hear me, please?
Yes, Dr. Howard.
Thank you. Dr. عبيد
غسان ما عرفتك. سوري ما عرفتك. أهلين.
Thank you very much for the information. It's a very informative talk, especially for our situation in Beirut and Lebanon. Just to go back to the issue of the vaccine, let me say, I will go basic. I will try to go to a little bit of the roots of the issue. Is that everybody is talking about the vaccine as of 2 weeks on, after Pfizer has declared that their vaccine is very effective. And we know that the technology for both Pfizer, BioNTech, and Moderna, the technology is new. And the safety has to be proven, has to be studied really very well. That's why there was a coalition of medical institutions and societies in the United States, and they came together to declare that they will not maybe back up any declarations about vaccines unless they are convinced of their safety. At least there was an earlier declaration like this early this month. We don't know whether it will be implemented or not under political pressure and pressure from people. Everybody wants to have the vaccine. But let me say that the Chinese vaccine, which is not publicized at all, we read about it sporadically already. But already we know that it has been tried in the 3rd phase study up to more than 1 million doses already, compared to the 30, 40, 50, 60,000 for the other vaccines maybe. What do you think, Dr. Abiad, in your really first-hand experience about the Chinese vaccine and about that possibility, especially that our country may not be ready to get, for financial reasons, for logistical reasons that you mentioned, the other more expensive vaccines? What do you think about the Chinese vaccine basically and logistically?
Anna, I don't have a lot of information about the Chinese vaccine and the methodology of, for example, storage and so on. And the issue, I think that, people need to have data. The good thing about the Moderna, the Pfizer, the Oxford, or the AstraZeneca, is that the data was made public and people were able to look at that, and there are now a lot of discussions, especially amongst institutions that have specialists in that field. The Chinese vaccine, we don't know much about it, or at least if there are information, it hasn't been as well shared amongst the rest of us, the rest of the scientific institutions, as the others, as far as I know. I think that, let's go back from the vaccine and talk about, for example, a medication such as remdesivir. So, initially it was considered to be like the magic drug, and there was a lot of pressure on the FDA and all the others to use it under emergency protocols. And we were part of the WHO study, the big study that showed that actually it's not that effective, and the results of using it were not impressive at all, and the WHO actually dropped it from the study. So what I'm trying to say is that we have been there before, where something comes out, there's a lot of promise in it, and probably some people would rush to use it, and sometimes even right, left, and center with no evidence of benefit, or in cases where we know it doesn't benefit. So I share your concerns. Are we rushing with these vaccines and so on? Now, from a Lebanese perspective, from a Lebanese perspective, I think that because we are not that rich, so to speak, we will not be the first ones to use those vaccines. And I think that there will be a lot of usage for them in Europe and the US, and we will know whether these vaccines work and probably about their side effects before this vaccine reaches us. This is my feeling.
Thank you, Firas. Any other questions from the
Thank
floor?
you. Thank you
Yes.
both.
Thank you, Hassan.
My name is Elsa again. So I think at this point we all agree that the vaccine is somehow far, so we're not gonna get it in the next 2 months, and even if we get it, its effect is not gonna show, and we still need to have social distancing and all the other requirements. My question is, why don't we use a rapid test, an effective test, even a test that has a lower sensitivity than a PCR, but that is more easy to use at home, or people could use it easily, could test themselves every other day before going out. And this way, people every other day instead of catching them 5 days after they do their test. And how effective would this be in reducing the infectivity rate? If I know that I am COVID-19, I wouldn't go outside. As if I don't know and I wait until I get the symptoms to go to the test, then I'll have wrong contact behind me. So, as part of our response to COVID-19, where is this in the discussion of the government? Because I've been reading a lot on social media, and specifically Dr. Michael Mina. I don't know if you know him. He's an epidemiologist at Harvard. He's an activist towards this technique specifically. So what do you think?
Yeah. So I read the article by Michael Mina in the Time about the use of the rapid antigen test, and it's a very good review on the topic. And I think that first, the good thing is that now it is available in Lebanon, and indeed I think it is going to help us a lot in this. But the problem that you're talking about, Elsa, goes beyond that you or me might go get some and do testing at home. The issue that you're talking about is what is our national strategy? What is the strategy that we have all over in Lebanon to be able to control the COVID and be able to reach what some people, if you also follow them on social media, the Zero COVID and Zero COVID Lebanon group. And this is where, if we have testing for everybody every couple of days, especially using these low cost tests, maybe we will be able to reach that. Let me tell you what are the obstacles facing that. So let's take somebody coming from, especially poor people who, for example, they work their day jobs day to day. Those people, they have zero protection in their jobs, i.e., if they go and they tell their employer that they have COVID, they will be kicked out. They don't have paid sick leaves. Their employers will be very much concerned that even if they are free from COVID, but because they have the stigma of COVID, this might somehow affect their business. I remember, for example, at Hariri, when we said that Rafiq Hariri will start taking COVID patients, at one point, no taxi used to agree to take you to next to Hariri. The whole area, we had, there were no cars coming to that area. And I'm not joking, really. The whole area becomes stigmatized just because Rafiq Hariri said we will start taking COVID. We had only one patient, by the way, at that time. So what I'm trying to say is, and I will come to the testing, but even beyond testing, the problem is that unless you have a way to support people who gets positive and have, such as I said, protected sick leaves and so on, and protected jobs, and we have a lot of problem, even if people know. That's why some people, they don't even test. When they have some symptoms, they don't go test because they are worried if people know that they are positive, how will they treat them, and so on. For example, some of our employees, just because they work at Hariri, not because they are COVID positive, they told me, so their neighbors refused to go up with them in the elevators, and so on. Now, coming back to the testing, and this is something that Dr. Arawi started alluding to early on, and that is, if we do not have a testing strategy in the country, can we catch COVID early and will we be able to be in control? The answer is, without a very proper testing and tracing, where we not only do the tests, but once we know who is positive, we go after the contacts, we will not be able to bring COVID under control. And what we will be doing is we'll be going from open, close, open, close, open, close. And unfortunately, this is the track that now we appear to be following. The problem with the rapid antigen, at the moment, and this is something I talked about in my tweet, is who is going to report? If you, Elsa, took that test, you did it at home, and, for example, you found out that you're positive, who will force you to call the government and say, I am positive, I'm going to isolate myself for, let's say, 7 days or 10 days, and these are my contacts, go do their tracing? What we think will happen, that some people, I'm not going to say most people, but some people they will know and they will not tell anybody, including their contacts. And this is the issue with we're gonna be seeing with some of those tests. Now, there are other issues. For example, there is a higher positivity rate with them. What is their role in the asymptomatic? Do they catch asymptomatic and so on? So, in a conclusion, they are going to be helpful, yes, but they are not going to be the silver bullet.
Yes, I see your point, but what I meant, Kamena, was if we use them, would it reduce the infectivity in our communities? Or
it will allow, yeah, sorry, go ahead.
For example, if we use them in elderly care houses, would it be better than not using anything? If we use them in our hospitals, be better than not using anything? In our schools,
of course.
So,
the major thing about them is time, in my opinion. The good thing about them is that they will give you the result very quickly. So, for example, the major drawback of a PCR, especially if you're doing a large number. So supposing you say, I want to go to a school where I've had a report of 3 positive cases, and I want to do screening on 500 students. A lab would probably take between 24 to 48 hours to give you back the results.
Yeah,
with this rapid antigen, you will be able to get the results probably in around 2 hours or 2.5 hours for a batch of 500 testees. So they really, I think the time issue with those rapid antigen tests is extremely important.
Yes, I just want to say one last statement is that for me, as I had kids, yani, I would rather send them to a school where any test is done just for more safety would be better than no test. If there is no alternative, if we can't do a PCR for 200 students, at least do some tests to ensure some sort of safety versus no safety at all.
So Elsa, in this case, let's listen to the question that Madame Bahira asked, because she's a mom. Unless Firas, you wanted to say something?
No, Anna, the only thing is I agree with you, although, you know, as you're saying, I'm starting to think about equitability and what we will have as we start using this, especially in schools who can afford to test their students like 2 or 3 times per week, is unfortunately we're going to have, you know, the rich schools that are functioning well and the poor schools who cannot do that and they are not functioning as well. So unfortunately, you know, with COVID, it's like, you know, Pandora's box, you know, every time you reach something, 3 other problems arise.
So discrimination is a very important issue. Certainly, Madame Bahira.
Yes, thank you. It's a very interesting discussion, and the information are very important. Thank you so much. I wanted to ask something. I've read that the UK they have outlined a plan, and they're going to use the Moderna vaccine, but they're going to prioritize this for eldest people. So, is there a plan here in Lebanon? How we're going to use the new vaccine, and is it going to start with the elderly first? And another thing,
yes.
Yes, sorry.
No, go ahead. Second question.
Okay. Is it going to give us a long immunity? So I'm not sure yet if this is in the discussion or yet it wasn't answered. I didn't read about it. And one more thing, I'm not sure, maybe Dr. Talia talked about this as well. Does it stop us from becoming severely ill, or does it stop spreading the virus? So mainly, what is the act or this vaccine does? Thank you.
So thank you. So the first question, I think the UK, because, you know, unfortunately how Jingo plays in it, but because Oxford and the AstraZeneca is a British vaccine, I think this is probably going to be the vaccine that they will be using a lot. And here in Lebanon, there is now a committee that is working on the logistics of the vaccination. I'm not part of that committee. But that committee is it has said is that it's going to prioritize the healthcare workforce, the frontliners, and the people at higher risk, i.e. The elderly and people, you know, especially the elderly people with comorbidities. So this is what we understood up till now from what that committee is saying. But, you know, we await to hear more from them. Now, concerning the vaccines, the issue of the sick patients or decreasing the rate of severe cases, that came out in the Moderna study. In the Pfizer study, there wasn't information about that. But in the Moderna study, yes, it showed that the group that received the vaccine, there was no incidence of sick cases amongst them. Concerning the spreading, 50% of the cases that have COVID are asymptomatic, and probably a lot of the spreading happens in these asymptomatic or pre-symptomatic cases. And the Oxford vaccine, the AstraZeneca, did address that, and it showed that there is a decrease in the number of asymptomatic cases. So we are hopeful. Now, finally, for how long? We have some studies coming from patients who already got the COVID, and it is apparent, or some of those studies suggest that the immunity stays longer than we expected. Now, what happened is that people, they thought about, immunity from studies on the antibodies and how long do you maintain having antibodies in your blood. And what was disappointing is that to see that the level of antibodies in some of the people seemed to drop with time, which raised the question about whether that immunity is only short-lived. And then there was this theory about that this is mainly a cell, it's a cell-mediated immunity, not a humoral immunity. But now some of the longer, studies seem to suggest that the immunity lasts longer. I think we will need more time. Remember, it's only 1 year since we've started having this virus. So it will take us more time to answer that question.
So Firas, I want to be respectful of your time, but just to highlight the committee, since I happen to be part of this committee اللي حكيت عنها, we have not reached a final decision. We're starting to prioritize, but one of the issues on the table internationally is whether it is okay to prioritize elderly or whether we should prioritize that population where we think the vaccine will have more impact. Particularly بمجتمع شرقي مثل مجتمعنا الكبار بالسن عندهم قدسية, so to speak. They are not disposable. So this is a big question on the table. If you have any last words, again, I want to be respectful of your time. The floor is yours.
No, not at all. Thank you for having this meeting. And I always think that the opportunity to come out and share the information actually helps a lot in the spreading the awareness. I really believe that even all our community, if treated as adults and not be patronized, I think we will have a much better participation from everybody and acceptance of what we do. And, for me, for example, my Twitter account was not that active before all of this. But, as this pandemic started hitting us and hitting us hard, I thought that I wanted to share some of those information and to see how things are received. And I must say it has been a very good experience for me, and I'm very thankful and humbled by all of your nice comments. And I think that this is one thing to learn, and especially from us physicians, is that we need to be more proactive. We need to be a better patient advocates. And doing that is by talking to patients, sharing the information, and treating them as adults and not patronize them. Thank you, Thalia.
So what a better way to conclude, what a better way to conclude the Kawakib webinar. Bless you, and thank you very much, Firas. I know how busy you are. Thank you all.
Everybody. Thank you.
Have a good night. Okay, bye-bye.
Thank you.
God bless.